begin by introducing the topic for tonight, which overall is working for health equity. That is something that had been realized a number of years ago, as our guest will explain, that this was an issue that needed a great deal of public attention. And to help us understand the issues around working for health equity this evening are Dr. Kierra Barnett, who is at the Kirwan Institute for the Study of Race and Ethnicity. She was a postdoctoral researcher there and is now a staff person, I understand. Welcome, Dr. Barnett, and thank you for taking the time to join us tonight.
Thank you.
And we also have with us our Montgomery County Health Commissioner, Jeff Cooper, and he is the Commissioner and Director of the Public Health Dayton and Montgomery County. Thank you, Commissioner, for coming on tonight. We really appreciate your presence and your time.
You're very welcome, Diane. Thank you for the invitation.
Thank you. We're going to start tonight with I should remind the viewers that this is a call-in show. So if something piques a question in your mind about anything that's being discussed, please feel free to give us a call, and we will do our best to get your questions answered right here on the air. I'd like to begin tonight by looking at and trying to help us understand what the social determinants of health. So there is a slide that is present for the viewers to see, and I'm going to start by asking Dr. Barnett to walk us through this slide to explain to us the interrelationships and what the pieces of these determinants are. Take it away, please, Dr. Barnett.
All right, so if we start at the top of this graphic that we see, that green area starts off looking at health outcomes. And so really we can break health outcomes into two categories. So we have our length of life and then our quality of life. And oftentimes when we are looking at health, that's kind of what we're looking at. We're looking at mortality rates, we're looking at life expectancy, or we're looking at comorbidities from different ailments. And so that's that green part. But if we want to say, okay, well, where do these health outcomes come from? Well, we start to look at that blue box. So those blue boxes are our health factors. When we take the first one, we look at health behaviors. So we look at, are you dieting and exercising? Are you using alcohol? Are you smoking tobacco? And really what this research has found is that those health behaviors only really contribute to about 30% of what makes up a population's health. So then we move down to that second set of boxes. That's that clinical care. So that's access and quality of the care that you receive in the healthcare setting. And that makes up 20%. Now, what's important about this is oftentimes when we think about health and how we're going to address health inequities, we focus on those two boxes, right? So if we think about, maybe we have a community with high rates of diabetes, for example. Well, we might start to look at, well, we might plan interventions that look at diet and exercise within the community. Or we might look at getting people in the community access to a physician to make sure that they're taking the right meds that they might need. And then that's kind of where our conversation stops. But what this diagram is really showing is that, well, that's only 50% of the pie. So we got to start looking at those other issues as well. And those other issues are social determinants of health. So that's that social and economic factors and that physical environment. So in the same example of a community with high rates of diabetes, we might start asking questions like, okay, well, what access to healthy foods exists within that community? Are there safe neighborhoods and sidewalks that the community can engage in physical activity in? And so it's about how do we look at the different access to opportunities or the different access to resources that a community might have. And then the bottom in that orange box is the policies and programs. So it's thinking about how do we create policies and programs that are going to impact those health factors that will ultimately impact those health outcomes.
Wonderful. Now, are these things measured in a standard way across the country?
In terms of social determinants of health, unfortunately, no. Okay. What we see often, and we'll get to that a little bit later, is that we can measure these different indicators in different ways. When we talk about from a community level, why it's important to fill out our census, because when we want to use that data to look at these factors at a community level, oftentimes we're reliant on the census data to give us the most accurate data of kind of what does this look like within a community.
Okay. Commissioner, would you like to comment on these, any or all of these pieces of these determinants of health?
So sure, I'd love to give you a perspective, and I thought Dr. Barnett did an excellent job of summarizing that information. So we at Public Health Dayton and Montgomery County, we create every several years what we call a community health assessment. And our most recent version is from 2019, where we assess the health status of our population as a whole, all 531,000 individuals who call Montgomery County home. And so if you look at that assessment from 2019, and if you look at that as the previous assessment from 2014 and the previous assessment from 2010, you'll notice that the data have not changed very much over that time span. And we find that there's this continual trend of historical disparities in health outcomes among population groups as well as communities. And so, in all honesty, Montgomery County's white population lives longer, has more economic stability, experiences less burden of preventable disease and violence, and benefits from better access to health care. Whereas, and it's very sobering, Montgomery County's Black, Asian, Native American, and other minority populations and individuals of Hispanic and other ethnicities, they tend to fare much worse, and they have less opportunity to be healthy. And so as we just walked through that diagram, there are clinical issues associated with those disparities in health outcomes. There are social circumstances that we refer to as the social determinants of health, economic and physical environment differences, as well as behaviors, as Dr. Barnett had indicated. And that's what we refer to as the social determinants of health. So it's access to care, it's education, it's employment, it's housing, it's transportation. And then the question we need to ask as a community is, well, what's contributing? What component of those social determinants of health? What are the key drivers of that? And it's issues such as poverty and racism and discrimination, adverse childhood experiences, trauma, violence, toxic stress. So it's all of those factors we need to ultimately be looking at root causes to change those social determinants of health to lead to better health outcomes in our population.
Good, thank you. Dr. Barnett, did you have anything else to add on that at this time?
Yeah, so thinking about that community health assessment that Montgomery County did, one of the great things that I find in that is that you also included maps of where do you see tobacco and alcohol vendors. So when we talk about the differences in behaviors, well, some of that is systemic about where do we allow different establishments that promote unhealthy behaviors to be established, in what areas do we see them in a far less quantity of. And so we have to, again, go back to like thinking about the way that communities are structured and how we got to where we are in communities. And that's really important to think about as well.
Oh, thank you for that comment. We are going to get to a map in a few minutes, and maybe we can explore a little bit more detail on that. Commissioner, with the, we went to the map now, but we'll come back to it. On the analysis that was done, the two most recent ones that we've had, are there certain things that, I mean, you've mentioned some already, but are there certain disparities that we have tried to make interventions in and we have not been successful? And are there some where there have been targeted interventions which have worked? I mean, because I know it's not changing as much as we all want it to, but underneath that, if you could say a little bit more about what's remaining the same and what has improved.
Sure. So, and that's a great question. Thank you for that question. So when we look at the leading causes of premature death in our population, and we can track this back for many, many years, it's heart disease, cancers of all types. Accidents now are the third leading cause of premature death, and a lot of that's a function of the unintentional overdose death and the opioid crisis. Then stroke and respiratory diseases such as emphysema and COPD, diabetes, etc. Well, when we look at a lot of those individual leading causes of death and we track them over time, there's a disparity in health outcomes among population groups and races. And so there are geographic differences. So for example, Black males tend to have a very high death rate for diabetes compared to white males or the general population as a whole. Black individuals tend to have much worse health outcomes for cancers of all types, as well as heart disease compared to the white population. So I guess to answer your specific question, we still have those disparities in health outcomes, and they've been present for decades. I think there's cause for optimism though, and I think that's a function of our community over the last several years understanding the need to work together to achieve collective impact. And by that, I don't want to get into a lot of detail, but meaning that we would have a common agenda, a common work plan. We would have mutually reinforcing activities. We would be sharing our data to try to show improvement. And a couple of examples of that are the Community Overdose Action Team that is responding to the opioid crisis. We have an Everyone Reach One maternal and infant vitality task force that's trying just desperately to reduce the racial disparity in infant mortality, meaning the number of babies that die before their first birthday. And then we have a food equity coalition that is trying to improve food security throughout Montgomery County, because if you look at our health assessment, you will notice that there are many what we call food deserts within Montgomery County. And it's a very frustrating issue. I mean, no child should go to bed at night because they're hungry. And unfortunately, there are disparities and inequities in terms of which children are going to bed at night because they're hungry. And so I would say there's cause for optimism. Yes, we have a long way to go. We're nowhere near where we want to be, but certainly we have now a better understanding as a community how to work collaboratively to show progress.
Thank you. We appreciate that. Dr. Barnett, did you have anything more to add on that topic?
Yeah, I would just want to add that this is not exclusive to Montgomery County. For as long as we've been tracking health data disaggregated by race, we've been seeing disparities between white and minority populations. And one of the reasons is we talk about like not seeing this drastic change that we want. It goes back to that first graph. A lot of the programs that we do and we have been doing in the past have been on that 50%, that clinical care and that behavior. And to address those social determinants of health, that takes policy, and just to get a policy passed, let alone enacted, and then see the fruits of that labor takes years. And so I think it is a positive that right now we're having these conversations about social determinants of health, that we're moving our focus into that area, but we also have to recognize that the outcome that we want is going to take some time.
Thank you very much for that. One of the things that seems to emerge, and you professionals help me understand this and help the viewers understand this, a lot of the things that you've mentioned, some may be genetic and unfortunate luck as far as diseases go, but others are sometimes preventable with education and with attention to these things very early on. So I'd like you all to comment a bit on that, because the health education is something that it too often happens in a physician's office maybe, and not enough out in the broader public, which is one of the reasons I wanted to talk about this show tonight, to bring it to viewers, and so that we could talk a little bit more about those types of things. Commissioner, you mentioned a lot of partners and the different coalitions that are working together, which is all very positive. Which ones are maybe addressing the education of our community about what behaviors can reduce the risk or what behaviors can improve health?
I would say that all the coalitions that currently exist within Montgomery County, whether it's the Community Overdose Action Team, the Everyone Reach One Maternal and Infant Vitality Task Force, Food Equity Coalition, LGBTQ Health Alliance, and there are several others. All of them have an education and information component. But as Dr. Barnett indicated previously, that's one component, but we really need to be transitioning as a community to, well, let's take a look at our existing policies, both within our respective organizations, as well as how we're then serving the community. So let's look at our policies, and then how do we get systems level policy change? So not at the organizational level, but for example, our transportation system or our housing system or our school systems, et cetera. We really need policy change, systems level change, and then ultimately changes to the built environment to where every individual within Montgomery County has the same or equal opportunity to be healthy if they choose to do so. And at this point, you know, the unfortunate reality is that not every individual has the same opportunity, and oftentimes many individuals, especially lower income individuals and individuals, minority populations, they tend to have more barriers in place to good health than their counterparts.
Thank you very much. I do want to just remind viewers that the number to call into the program is 223. The number to call into the program is 223-5311. I'm sorry, my office number just rolls out of my mouth. So that's what it almost did here. I'll give that at the end, but to reach DATV, it's 223-5311. So we have had one person call in that wants to thank Jeff, Commissioner Cooper and Dr. Barnett for the speakers and for an insightful program. So thank you. Let's keep it going here. Tell us a little bit. We've heard about many of the partners in Montgomery County, but let's hear a little bit about the partners that the Kirwan Institute is working with at the state level, which are broader and more encompassing because you got a lot more territory and population to cover. So tell us a little bit about how your agency is partnering for these same goals.
Absolutely. So for the viewers that are not familiar with the Kirwan Institute, we're actually a research institute within The Ohio State University. And so we partner a lot with different state level, but also local public health agencies as well. And so we have a partnership, especially right now during COVID-19, we've been working a lot with the Ohio Department of Health. We have partnerships with the Ohio Commission on Minority Health, which has programming in various locations and counties across the state, including one of the projects that I work on specifically has a new hub in Montgomery County. And then we also work with our local health departments in Columbus and also in other parts of the state and the country as well.
Okay, very good. I wanted to also ask a couple of questions about the other parts of social determinants of health that may not be in health departments or research institutes normal, job description or mandate or even within their control. Because you talked about how we build things and how we how we are structured and how we live in our neighborhoods. So, let's take first of all, how, Commissioner, are our cities partnering with some of these coalitions to look at when they make improvements, how to do things that would help improve health of the people that are going to live in that area?
That's a great question, Diane. I would say at this point, we are in the very early stages of the educational component for impressing upon our community, meaning Montgomery County as a whole, and all of our jurisdictions, the need to focus on health equity and a health equity in all policies approach. I think what would ultimately be very helpful. And unfortunately, and I don't want to use this as an excuse, but this COVID-19 pandemic has really forced us to divert the vast majority of our resources as a health department to managing the pandemic. And so our hope is that as we move forward and a vaccine's developed and we can return to a lot of our traditional programs and services, we can really focus on getting a health equity in all policies approach in place. And so I would say, though, based on our interactions with our jurisdictions, that all would be willing to take a look at adopting a common type of framework or tool by which we would be making these internal assessments of how we conduct our business as organizations and what strategies we're doing internally. And then how do we all fit into under a larger umbrella as a county to make sure that all of the work we're doing is reinforced by each other. So we're in the early stages of trying to determine how do we tackle this as a community. And I will say that if it were for something easy to do, and if there were just a standard template that we could all adopt and implement, I don't know that that exists out there. And so it's going to take this entire community and coming together to think strategically about how we do move forward and enact this type of change. I'd love to hear your comment or your thoughts on that, Dr. Barnett, as well.
Absolutely. So it's the same. So it's that really emphasizing that health equity in all policies kind of sort of framework. And how do we get buy-in from our, partner agencies that, like you mentioned, they have nothing to do with health on the surface. So if you think about a housing HUD agency, they don't have anything to do with health, but we know that housing is the foundation of having good health. And so we have to figure out how do we, get the buy-in from them to take a look and do an assessment of their policies and figure out what policies do they have within their organization and how they do the work that they do that's health harming to certain populations. Yeah. And that takes work and that takes buy-in. And I think it's going to take some re-education of folks in different fields to understand why we care. But I would agree that because of COVID-19, it's bringing a lot of stuff to the surface, especially around social determinants. And hopefully this is a point in our country where we can start to make that shift and understand how all of these things are interconnected.
I agree. And if we can make changes and improvements in social determinants of health and ultimately address root causes, all of us will benefit. That will benefit our entire community. And we all want to live in a healthy, safe, and thriving community. So whether it's an issue we're working on around infant mortality or chronic disease such as obesity or diabetes, etc., if we can have improvements in the social determinants of health, specifically, we know if we make improvements in public safety, we will all benefit. If we have better opportunity and reduce barriers that some people have regarding transportation, we will see health improvement. Same thing, if we have safe and affordable housing, we'll have health improvement. If we continue to invest in education, all of those factors need to be addressed, and every sector out there needs to be adopting a health equity in all policies approach to make sure that we're contributing as a whole to the greater good.
Yes, I would like to take this opportunity too to congratulate Commissioner Cooper and his staff and his board on receiving an LGBT award for being stellar in your response to that particular community's needs. And I understand, do I have it correct that it's the first one in the state of Ohio, or have I aggrandized you too much?
No, well, thank you for that recognition. We are very excited. We are, when we first started forming a coalition and made the commitment as an agency that we wanted recognition by the Healthcare Equity Institute as recognized leader status nationally. There was one other health department in the state that had that leadership recognition. And so now we have, I'm not sure if they still have that status, I don't know, but we may be the only one now, the only local health department in the state of Ohio that has recognition by the Healthcare Equality Index for our work around improving access to care and care to the LGBTQ community. So we're very proud of that accomplishment.
Yes, and you should be. I have a caller that has given me a question to ask to both of you. And this question involves the closure of Good Sam Hospital on the west side of Dayton. And the caller stating that, of course, now those who live in the west side have less access to health care. And the questioner is wondering if Good Sam might have faced greater opposition in this closure and removal if the decision had been taken during the current or present of Black Lives Matter movement. So I'm not trying to be unfair to you, Dr. Barnett. I don't know how much you know about Dayton, but I do know that you know a lot about the opportunity mapping that we're going to look at a minute. So, but Commissioner, would you like to make a comment about what might have been?
Well, I certainly don't want to speculate, but I will revisit the discussion that we've been having around factors that influence health. And so, as Dr. Barnett had indicated, obviously our behaviors as individuals have a significant impact on our health status as an individual and as a population. Our access to clinical care is important, but it's only one component of those modifiable factors that influence health. So we need to be looking at physical environment, yes, clinical care, both medical, dental, and behavioral health care, as well as changing our behaviors as individuals. That's paramount. And so, for example, if you look at our behaviors, if we could, as a community, exercise more, eat a healthy diet, stop smoking, because almost a quarter of our adult population continues to use tobacco on a daily basis, and avoid overconsumption and or abuse of alcohol and other drugs, we would see significant improvements in the overall health of our population. That doesn't mean that access to care, clinical care, is not important. It certainly is. But we know that there are many factors that influence our overall health.
Thank you. Dr. Barnett?
Yeah, the first thing that comes to mind, and I keep coming back to this point, is like every time we talk about behavior, my mind goes to what does the resources in that community look like? That's always my go-to. So when we think about, again, being more physically active, and it might not be that you need access to a gym. You might just need access to sidewalks, and there are plenty of communities that don't have sidewalks, right? So that's one barrier to being physically active. When we think about, again, going back to like smoking and tobacco, as I mentioned earlier, where do we see, the overwhelming amount of tobacco and alcohol vendors? What communities do we see those in? And so if we want to change those things, then we also need to look at policies around, where do we see these, where do we see certain resources and the lack of certain resources? And then if we change those things, then we'll change the behaviors that follow.
Thank you. I'd like to turn our attention now to the opportunity mapping. And I'd like to start, well, we have an opportunity map, the overall opportunity map of Montgomery County here on the screen in front of us. And I do want to tell the viewers that there are multiple versions of this map dealing with many different individual topics, and Commissioner can highlight that more. And that's available online. So if any viewers have a particular issue that they want to check for, there's probably an opportunity map in there. But first, I'd like to ask Dr. Barnett, please explain to us really what is opportunity mapping and what is its value for us and our bringing equity into health. Help us understand this tool.
Absolutely. So this opportunity mapping tool was something that was developed by the Kirwan Institute many years ago. And basically it's the way that I like to look at it in public health. So also want to emphasize that Kirwan Institute is not traditionally a public health institute. We work a lot within public health, but we also have arms in a lot of different sectors. So this opportunity index was originally developed, I believe, around housing and trying to understand where do we see inequities in access to housing. But we can use it in public health, right? So the methodology has usefulness in public health. So what this opportunity map is that you're seeing on the screen now is looking at social determinants, if you will, across 3 categories. So we have income stability, health and safety, and education. And so this methodology allows us to look at multiple variables. So we have unemployment rates, median household income, we have low birth weights, percent of the population with health insurance, so on and so on. And it allows us to take those variables and index them into a single kind of outcome, if you will. So that outcome is like, what is the opportunity in this neighborhood? And so what we see on the map is as the colors get darker, we have more opportunity. So these are people in areas that they have more access to resources than in other areas as well. And so, like as mentioned, this is one example of this map. One thing about our opportunity mapping methodology that's great is that we can pick and choose what indicators we want to look at, because there might be a health outcome that you might be interested in that we know that, well, that is really related to air quality, or that outcome is really related to housing. And so we're able to, through this methodology, pick and choose kind of what indicators we want to include. But regardless, and as you mentioned, there are multiple opportunity maps that exist for Montgomery County and other areas as well. But the pattern is, no matter what indicators we put into the system, the map pretty much looks the same. It comes out the same, where we have these areas that are prone to have very low opportunity, and then areas with very high opportunity. And when we look at this map of Montgomery County and we look at, well, who's living in these areas, we see an overwhelming majority of the population, our Black and brown population in Montgomery County, are living in those very low opportunity areas in comparison to those very high opportunity areas, which is where we see our white population.
Thank you. Commissioner.
I agree completely. The opportunity map that we're talking about was really our first attempt at reviewing and understanding the tool from the Kirwan Institute. So that diagram that you see is our very first opportunity map that we created as an agency. If you now look at our health assessment, we've kind of transitioned from that opportunity map to then having more zip code specific data in our health assessment, and we've created geographic snapshots. And so in each of those geographic snapshots, we have kind of broken health and health factors down in associated with housing, economics and employment, education, hospital visits, access to supermarket, etc. And a statement really, it was made several years ago by a former director of the Centers for Disease Control and Prevention still holds true. And that is that your longevity and health are more determined by your zip code than they are by your genetic code. And so whether it's an opportunity map or our health assessment or any other data report that we generate as a health department, they all tell the same story. They may look a little different, but the story remains the same. And that is that we have significant disparities in health outcomes among races. A lot of that is related to the social determinants of health, and we really need to focus on those root causes for long-term change.
Okay, that's very important. Thank you very much for that. And now that we've moved to doing the individual assessments, those are more specific and more drilled down and more detailed than what these general maps are for us. Isn't that correct?
Yes, in a sense. And we also then have very specific data reports on our website as well. So we have a multitude of reports that focus, for example, specifically on infant mortality and maternal and child health. So it's just, think of it as another tool that we can use to tell the story of what we really need to do as a community. So we have a broad brush of, this is an opportunity map. We then generate a health assessment. And then depending on the specific issue, we have a variety of very specific data reports that we generate.
Okay. Are those then turned into recommendations for policy change?
Oh, absolutely. And there are also data reports, and all of these documents are used by our existing coalitions. And when I say our, I mean that as the coalitions that are occurring within Montgomery County. So yes, our agency is about data-driven decision-making. And so no question, we use these reports and these data and will ultimately be using them to drive policy and systems level change in our community.
Yeah. That's wonderful. It's a step that, as an agency, that you have already taken with respect to this issue, a very big step with your board, with the Board of Health resolution passing their health equity in all policies resolution just at the end of last year. So stepping forward to say, at least in this agency, of course, they don't rule or manage, so to speak, other agencies, but in their agency, that's a big step to do what can be done. Would you like to say a little bit about what such a wonderful goal in that policy means for the change in activities within your agency?
Sure. I mean, it forces us. I mean, it demonstrates our commitment to not just asking other entities to do this, but having us look internally as well about applying an equity lens. So how do we know that the decisions that we are making are not going to have an unintended negative health consequence? So we really should be reviewing all of our internal policies and procedures aimed at improving the health and safety and professional development of our workforce. But at the same time, all of our community interaction and our public facing programs, how are we applying that same, quote, equity lens to our community-based work? So we were very excited when we worked with our Board of Health to pass this resolution last December at the Board of Health's meeting. And then we have subsequently followed that up with a declaration this past July on racism and discrimination as a public health crisis. So, but the initial health equity and all policies approach resolution adopted by our Board of Health basically says that in everything that we do, we are going to look at policy, system, and built environment change, and we're going to engage all stakeholders and ask them to do the same thing, because that's ultimately the way that we will show health improvement as a county.
Okay. All right. And Dr. Barnett, are you aware of other departments who have taken such bold and good steps?
Absolutely, especially around the racism as a public health crisis. We're seeing that a lot now, given everything that's happened. I know our former APHA, which is the American Public Health Association president, Dr. Kamara Phyllis-Jones, when she was president in about 2017 of our organization, was really adamant about nationally bringing that issue to the forefront around racism as a public health crisis. And now, given everything that we see playing out in our society, we're seeing a lot of public health departments pick up on that initiative as well, which is really great, because hopefully our departments are doing more than just lip service, and we're also ready to do the work that it takes to actually address racism within our communities.
Right. And I think that with many of the pieces of the implementation of that policy, I think that the community-wide will be interested to see when information about that is made available, because I think many organizations are looking to do that as well. So I think this is another area where public health can be a leader in our community. And it may not be a template for everybody, but watching what changes do get made is a very good example that others can certainly follow. So that's wonderful. I wanted also to say, do we have a top few goals for our partnerships to achieve? I mean, we've talked about policy change. Are there some that you would like to highlight or put out there that are maybe receiving the most attention or the highest level of attention at this point in time?
I would say that I don't know that there's anything that's elevated to a ranking or anything like that right now. I will share with you that I think a logical starting point for all organizations is to really understand terminology around equity and inequity and racial equity and racism and non-discrimination. So I think initially education and awareness and understanding of our own biases and implicit bias, I think that's a logical starting point for all organizations. And so Public Health Dayton and Montgomery County is actually, we're going through a process now of starting implicit bias or unconscious bias training for all of our employees. And that's actually starting now, and over the next month or so, we'll at least have that initial awareness training on implicit bias as an agency. And we would ask all community partners to do the same thing, because I think our work around equity and racism and discrimination, ultimately we have to have a strong foundation and a base level of understanding of what we're trying to accomplish. So public health has passed these resolutions on equity and racism as a public health crisis. City of Dayton has passed a resolution on racism. Montgomery County has as well. And now we know that the Miami Valley Regional Planning Commission has a regional equity initiative where they're looking at this same issue. And so I think it's important that we all have a baseline level of understanding of terminology and what we're trying to accomplish. And then we need to figure out how, as an overall system of partners, we're all working under the same umbrella to where we can then measure our progress, because it's ultimately about creating a dashboard to report back to our community on the progress we're making.
Yes, thank you. And that's a tall order to get so many entities and so many agencies and so many, working on at the same, if not the same page, but in the same notebook or something. So Dr. Barnett, it must be nice to see communities such as Montgomery County, taking on some of the hard work that your institute has been working on and publishing on for some time now.
Absolutely. As Jeff was speaking, I was thinking about that shared terminology piece, which I think is really important. I think even as we talk about racism, having a shared terminology of what that means, because oftentimes we're kind of programmed to think about racism as what we call personal mediated racism, which is what one individual does to another. And oftentimes we forget about that institutional racism, which is really the beast that we want to attack. We have to understand the history of our country as well. And by history, I'm not even just talking about, slavery and all its remnants. I'm talking about the redlining that existed in our communities. I'm talking about the way in which we built highways that cut in and through our Black communities and and relocated communities and removed folks from resources that they had. And we have to bring all of that into the conversation when we talk about racism, because if we pretend like our past didn't happen and we don't actually address it, there's a lot that we won't undo. And if we don't undo it, then we won't have the health outcomes that we want to have.
Thank you. Very good. I also have a caller that is interested in asking if someone is interested in participating in trying to make a difference on any of these health indicators, and where would be a good place to start or who to contact?
I would contact our public information department, our information referral line at 225. I start with the area code 937-225-5700. And that's probably a good place to start. And then we can direct that individual to the appropriate area. But that's a general number for public health that would be a great starting point. Yeah. And certainly we know that for us to make improvement, and I'm glad that we have this question, for us to make improvement, we need input at the grassroots level. So it can't just simply be executive level leadership in organizations making these decisions. We need citizen input on what we really need to accomplish.
Good, good. Thank you. Thank you very much. I'm glad to have that number available. We don't have a lot of time left, I'm afraid, but I would like to touch on the whole COVID pandemic and how has this impacted our work on social determinants of health? How has it impacted work on health equity? It's brought so much devastation, but tell us from your points of view, from the worlds that you work in, what impact is this having on our topic tonight? Dr. Barnett.
Yeah, I can say that the Kirwan Institute has been being contacted left and right by different organizations across the country, wanting to get our input on what's happening, wanting to understand what's happening. And so I think that there's a heightened attention to social determinants of health and health inequities and health disparities going on right now, which again, it can be positive if we're actually going to take what's happening and use it as momentum to make change, a sustainable change. So I think that's great. What we know through some preliminary data that we see at the national level through different organizations and research institutes is that we know that our minority and our low income communities are impacted the hardest. They are the ones who experience more job loss. They are the ones who are experiencing the worst outcomes in terms of COVID-19. But they're also the ones, again, going back to what communities look like, they're the ones who are already living in overcrowded communities that lack transportation, that are low wage essential workers who are going to work every day, while some of us, including myself, had the luxury to work from home and stay safe. And so it's no surprise that we have those disparities. And it's no surprise that we might see health disparities worsen because of the pandemic, not only in terms of, who gets COVID or who has worse symptoms for COVID, but because we also have all of these social determinants that are being impacted because of the pandemic.
Thank you very much. Commissioner.
I don't know that I can say it more perfectly than Dr. Barnett just articulated. No question, the COVID-19 pandemic is raising a lot of issues and a lot more awareness around inequities and racial disparities. So for example, for Montgomery County, we know that Black individuals represent approximately 22% of our population, but they represent over 30% of the cases of COVID-19. So clearly a startling, stark revelation and data point. So if you look at if we look at looking at those data by rate, we know that if you're a Black individual residing within Montgomery County, about 1 in every 56 Black individuals has tested positive for COVID-19. 1 in every 122 white individuals has tested positive. So clearly a disparity. And no, none of us want to be in this pandemic. We don't want to see anyone affected, or we certainly don't want to see this virus circulating in our community or anywhere in the world. But it's forcing us as a system to understand and recognize and admit that we really do need to be focusing on reducing these inequities and making sure that every single person who wants to be healthy has the same opportunity to be healthy.
And thank you. Thank you. That I really appreciate that. I've been asked if you would give the public health number again.
Yes, it's 937-225-5700.
Okay. And I'd also like now to give each of you an opportunity for some closing or concluding comments. I'm sure there are things that you are of importance to you that I didn't ask you, and so now is your chance. Dr. Barnett, please.
Yeah, one of the things that I'm thinking about as we have this conversation and one of the things that we have to address as a public health crisis as well is housing eviction. We know that evictions have been a major problem in our country for a long time. We know that there is a lack of affordable housing nationwide. We also know that, again, our most vulnerable populations have been made more vulnerable because of this pandemic, and that we're going to see a surge in eviction rates. And so now that we have a population that's housing insecure in a pandemic, what does that look like? Can you go safely and live safely in a shelter if that's your only option? Or are you moving in with family? So now you're again creating that more dense more dense housing, where you're also gonna potentially increase the spread of COVID-19 as well. And so housing insecurity is one of those issues that I think we're gonna also have to really tackle in order to not only get past this pandemic, but get to achieving health equity.
Thank you very much. Yes, COVID seems to almost like, pulled up a blanket and to revealed a whole lot of problems that were there that weren't being looked at. Commissioner.
Yes, thank you. And I agree completely on the housing issue. No question, it's a major issue that we need to work on. I would leave our viewers tonight with a sense of hope. And I realize that we currently are continuing on with this COVID-19 pandemic. We have many disparities in health outcomes among races. There are existing inequities that have been present for decades and longer. However, we have a strong, long history of working together within Montgomery County to at least begin to address complex public health issues. I think we have good success with some of our collective impact models that we've talked about earlier around infant mortality, unintentional drug overdoses, and food equity. And we will apply that same vigor and commitment as we work as a system of partners to respond to the whole concept and fact of racism and inequities and discrimination. And so ultimately, if we want to get healthier as a community, we have to work together under a collective impact model, and we have to address root causes and social determinants of health that are leading to these adverse health outcomes. And I'm confident, and I honestly believe that our community, our system of partners at all levels want to do the right thing. Yes, it will take time. We need to understand that change doesn't happen overnight. But just by the virtue of the fact that we're all having these meetings and discussing these topics, this not a topic that was discussed 5 years ago or even 3 years ago. And so that's cause for optimism. And I'm confident that we will make progress as a community.
Thank you very much. And I'm very pleased to hear your optimism about that. Our Montgomery County does have a long history of pulling together and getting things done that need to be done. This is a very big one. This is a very big fight to take off, but we can do it. And I want to say that I'm afraid I'm going to have to end the program for this evening, but I can't do so without thanking you both for the wealth of information. I know that there's much more that you could have shared if we had had more time, but I would direct people to both the Kirwan Institute and the Montgomery County Public Health Dayton and Montgomery County websites, because there's a lot there to look at. So thank you very much for your time this evening, and thank you to the viewers for watching and for those that called in with their comments. If you have any follow-up questions, my office number is 937-223-4613. So again, I hope all viewers and everybody out there can work to stay healthy. Bye.